Okay, good evening, everybody. And welcome tonight. And thank you for joining us for Osteoporosis Canada's Bones and Beer webinar on MIN and osteoporosis in partnership with thinkbeef.ca. My name is Liz Kehler, the Community Engagement Coordinator for Osteoporosis Canada in the BC and Alberta region, and I will be your moderator today. So before we start, I would like to take this opportunity to acknowledge the traditional territories of the people of the Treaty 7 region in southern Alberta. The city of Calgary is also home to the Métis Nation of Alberta, Region 3. This presentation will provide general information about MIN and osteoporosis, and it is not intended as individualized health advice. If you have any questions on bone health and osteoporosis, consult a physician. And if time allows, we will have a short Q&A. To submit a question during the webinar, please use the Q&A feature located at the bottom of your screen. So with this, I would like to introduce our speakers this evening. First, we have our keynote speaker, Dr. Sid Feldman. He is a family physician in Toronto with a long-standing interest in fracture prevention and care of patients with osteoporosis. He is the chief of the Department of Family and Community Medicine at Baycrest Health Sciences and associate professor and head of the Division of Care of the Elderly in the Department of Family and Community Medicine at the University of Toronto. And our host and OC advocate, Larry Funnell, is a longtime volunteer with Osteoporosis Canada. Drawing on his lived experience, he serves on the Executive Volunteer Committee of Osteoporosis Canada's Canadian Osteoporosis Patient Network, and on the steering committee for the update of Osteoporosis Canada's clinical practice guidelines. So to start us off, I would like to welcome Larry Funnell. Over to you, Larry.
Thank you, Liz. I'd like to begin by acknowledging that the land from which I'm participating this evening is the traditional and unceded territory of Coast Salish peoples, specifically the Kwantlen, Katzie, Semiahmoo, and Tsawwassen First Nations. I'm delighted that you all chose to join us this evening for the first virtual Bones and Beer. So let's start by honoring the Bones and Beer tradition with a toast to men's bone health. So cheers, everyone. So I'm enjoying a delicious IPA from Farm Country, one of my favorite local craft breweries. What's in your glass tonight, Sid?
I've got a dry hopped lager from Ace Hill here in Toronto, Larry. It's delicious.
Yeah, mine too. It sounds like a couple of good beers. Arvin, could you please put up the first question? Let's look at some different beers from around the world. So you can read the question, but maybe I'll read it for you. Which of the following ingredients have been used in making a specialty beer? So just click on your answer. You see there's squid ink, Krispy Kreme donuts, lobster, collagen, none of the above, all of the above. So let's see your answers. Looks like the majority of you have answered correctly. And that is that all of those ingredients have been used in making beer, crazy as it sounds. I doubt many of us have actually tasted any of those beers or have the desire to do so anytime soon. So let's take, there will be more questions to answer later on, and some will be fun. Others are going to give us important answers that will inform our research on men and osteoporosis. So some of you might agree that many of our best ideas come from discussions over a cold beer. That could certainly explain where Bones and Beer came from. In 2011, Rick and I were enjoying a pint at the Elephant and Castle in downtown Vancouver. We puzzled over why so few men seemed to understand they were at risk of osteoporosis. And we shared our frustrations about the lack of resources to support those men who do have the disease. Inspired by the atmosphere of a packed pub with the after-work crowd and the beer and the ribs on the table in front of us, we decided that we were going to do something about it. We would hold our own men-only, man-friendly event to raise awareness of men and osteoporosis. And we would call our event Bones and Beer. So our concept was to invite men to an affordable men's night out in a familiar neighborhood pub. They'd come to be entertained by media and sports celebrities and to have their appetites and thirsts quenched. And then an osteoporosis expert like Dr. Sid Feldman would take the stage to shock them with the cold, hard facts about men and osteoporosis. So our idea was enthusiastically endorsed by Osteoporosis Canada. And within weeks, a team of volunteers was gathered and the planning was underway. Our first Bones and Beer in 2011 was held at the Pump House Pub in Richmond, BC. It was a roaring success and it set the stage for more to follow. So for the past decade, Bones and Beers have been playing to sold out crowds here in Vancouver and in Ontario, Manitoba, and Alberta, all spreading the word and encouraging men to take care of their bone health. Then came COVID and today's first of its kind, virtual Bones and Beer. So although we aren't in a pub enjoying a rib meal paired with craft beer, we did share with you a recipe for bistro-style braised beef and beer, courtesy of our partner, Think Beef. So now if we all had smell-o-vision, you'd be able to take in the incredible aroma of the Think Beef-inspired short ribs simmering in my oven right now. Can't wait to try it. So do try the recipe. I know you'll enjoy it. So it's time for a food question. Arvin, could you please put up the food question? So thank you, everyone. Clearly, there's a divided opinion on favorites and lots of others too, but ribs, especially of Bones and Beers, right at the top. So thank you, everyone, for filling in that poll. So now let me turn back the clock to share my story of osteoporosis. I suffered 8 broken bones prior to being diagnosed in 1998. I thought I was just a klutz. No one disagreed with me as the evidence was seemingly quite compelling. So a slip on wet grass, a tumble into an empty cardboard box, an unexpected pebble underfoot, all led to the same thing. Another broken bone, a trip to emergency, perhaps another cast, and months of physiotherapy. I suffered blinding pain. I endured lengthy periods of convalescence, watching helplessly while others performed even the simplest of tasks for me. I was unable to work and reluctant to socialize for weeks at a time, feeling increasingly isolated as the broken bones piled on. I broke bones in 3 different provinces and on 2 continents. I was treated for those fractures in 7 different hospitals. I saw dozens of healthcare professionals in emergency rooms, x-ray clinics, cast clinics, doctors' offices, and physiotherapy. The fractures themselves received excellent treatment and quite quickly healed, but no one connected the many broken bones to my bone health. No one, that is, until my wife's doctor heard my story. She took one look at me, grimacing in pain with my arm still in a sling to support my 8th fracture. She quickly dismissed my feeble attempt to break on the wet grass and the hard ground. And then she ordered me to immediately see my doctor to get my bones checked. Well, that was easier said than done. I didn't have a family doctor. Family doctors are for the wife and kids. I'm a man. I don't need a family doctor. When I finally found a doctor who agreed to take me on as a new patient, he listened to my story, he examined the x-rays of my broken bone, and he concluded, well, you're a man, you're not old, and you certainly aren't frail. You're going to be just fine. I admit I was somewhat relieved to hear him say that, but my wife's doctor's words were still fresh in my mind. So I insisted, and he relented, and I was off to get a bone mineral density test. The devastating diagnosis that quickly followed set me off on a long journey to answer two questions. Why wasn't I diagnosed much sooner? And was I doomed to a lifetime of broken bones? At first, I found it hard to comprehend. I have a woman's disease, but I soon learned that the stereotype of osteoporosis is not true. Men, in fact, far too many men, get osteoporosis too. I learned that it was not normal to break bones so easily, and that the kinds of fractures I had were the most obvious, but most often missed warning of osteoporosis. I learned that unless I received proper treatment, I would continue to break bones. And I learned that I was not alone. Of the more than 2 million Canadians who have osteoporosis, the vast majority don't know it. Men in particular seem clueless about their risk. So a while back, I spent an afternoon with Dr. Google, surfing the net in an attempt to create a list of the health issues that concern men. I narrowed the list down to the top 20. So you know what wasn't on the list? Bone health and osteoporosis. You know what was on the list? Back hair, flatulence, and bad breath. Boy, don't we men have our priorities straight. My osteoporosis journey has been a long one that includes a progression of medications, nutrition, exercises, and lifestyle changes. I've tried the medications that don't work and saw remarkable improvements from the ones that do. I learned that the weight loss diets I'd subscribed to were not bone healthy diets. And I learned the proper exercises would have a lasting effect on my bone health. I finally stopped breaking bones. My spirits lifted, my confidence grew, and I regained a quality of life that I had not thought possible. Now, more than 20 years since my last fracture, I realize that complacency has become my biggest challenge. A couple of weeks ago, I got up from the couch and in a flash, I tripped over my own feet and fallen to the floor with a tremendous thud. I laid there for a minute. I was hurting, shaken, but I wasn't broken. And even before I got up, I was repeating to myself two things. First was a mantra taught to me by my friend Sheila Bryan: always know where your feet are now and know where they're going to go next. The second thought was a single word: klutz. Thank you for the opportunity to share my story with you this afternoon. And now I'm delighted to turn it over to Dr. Sid Feldman, my friend and colleague, because I know he's going to help re-energize me to stay fracture-free and hopefully do the same for all of you. Over to you, Sid.
Thank you very much, Larry. Let me start by saying that I would like to acknowledge that I'm on the traditional territory of the Wendat, the Anishinaabe, Haudenosaunee, Métis, and the Mississaugas of the Credit First Nation. I recognize the significance of the Dish with One Spoon territory. The Dish with One Spoon is a treaty between the Anishinaabe, Mississaugas, and Haudenosaunee that bound them to share the territory and protect the land. Subsequent Indigenous nations and peoples, Europeans, and all newcomers have been invited into this treaty in the spirit of peace, friendship, and respect. And I want to thank Osteoporosis Canada and our sponsor, Think Beef, and my friend Larry for inviting me to come and speak tonight. I never tire of hearing your story, Larry. I think it has so many important and really critical messages for all of us. And I'm also very happy that I have the opportunity to have a refreshing beer while giving a presentation. That's a new thing for me. So thanks for letting me have that chance as well. I'm just going to take a sec and share my screen so that I can put some slides up. Can you see that okay? Great. So I'm really excited to be at this 10th anniversary of Bones and Beer. I'm sorry that we can't be in person, and I look forward to joining you perhaps next year in person where we can actually toast each other and have a good cheer together. So who gets osteoporosis? That's going to be the first thing that I want to think about with you tonight if we can. And I'd like to start off with what I hope is a bit of a warm-up poll. True or false, osteoporosis is a woman's disease? Phew. All right. So at least we're not starting back at the very beginning. Absolutely. And I think that that's really the most important, one of the most important lessons is that it's one of those very, very few diseases that is studied far more in women than in men. And so it really is something that I think is a condition that really we do need to talk about a little bit together. Okay, here's the next one. How many men break a bone due to osteoporosis in their lifetime? Is it 1 in 10, 1 in 7, or 1 in 5? This one will make you think a little bit. And I thought every time there's a poll, I might sip my beer. So there's 47 polls. Okay, so most of you know the correct answer, which is terrific, that it is 1 in 5 men who break a bone due to osteoporosis. It's 1 in 3 women who have osteoporosis. So really maybe a higher number than many would think, that it actually is a very significant and concerning disease in men. And just this last November, the Public Health Agency of Canada put out a new report about osteoporosis. And I know there's a lot of information on this slide. The one thing that a couple of things to point out, though, if I might. In the top left-hand corner, you can see that it's 2.2 million Canadians living and diagnosed with osteoporosis, more and more of them as we get older. And then in the middle, you can see about 25% of people actually die following a hip fracture every year. So this is not a fool-around condition. We know that this is a condition that has really serious outcomes, and we're going to talk a little more about that soon. And then if we think about men in particular, really 2 things I want to highlight. 1, men are 30% more likely to die if they do have a hip fracture. So we really do not do well after this particular event. And it's really important that we try and do whatever we can to prevent it from happening. Only after somebody breaks a bone, only 20% actually receive a diagnosis of osteoporosis. And it's even less likely in men than it is in women. Okay, think really carefully about this. Why are men less likely to get diagnosed and treated for osteoporosis? Which of these is not true? Men don't think that it's a man's disease. Doctors don't think it's a man's disease. There's less research on men than women, and treatment is less effective in men, which is untrue. That's right. So there's a bit more of a spread here, but that's correct. Our research does show that treatment is just as effective in men as it is in women, but that there are these biases that we have, both patients, but also physicians. We just don't think of it often enough when it comes to men. And I think really there is less research on men than women, unfortunately, when we look at many of the different aspects of treating osteoporosis. So we extrapolate from what we know about women and apply that to men some of the time. Well, some things really are important to know about osteoporosis. For instance, if you've had a fracture, it significantly increases the risk of having more in the future. And if you do break a bone, it can lead to chronic pain, immobility, a decrease in quality of life, a loss of independence, a high rate of needing to be in long-term care, billions of dollars with a B, billions of dollars to the healthcare system, and as said, a 25% chance of death if you break a hip. So really, really serious consequences of fracture. So I hope I'm making a bit of a value proposition that would say that this is something that we need to pay attention to. And unfortunately, we don't make that link. So many people who have had a fracture really don't think about osteoporosis. So I would encourage you, if you ever do break a bone or you know somebody who's broken a bone, that you encourage them to go to their doctor and to ask the question, do you think this could be osteoporosis? So we've talked a little bit about who gets osteoporosis. And now I thought what we could do is dive a little bit more into what is osteoporosis. And then after that, we can get more into the treatment of it. And I know there are some people on the call who probably are experts in osteoporosis far more than I am. And I would welcome your comments and input perhaps after I'm done. So if you want to know what osteoporosis is, I think what we should do is go back to the very beginning and think about how bone is actually made. And we're going to come back to this when we talk about treatment as well. You can think about bone as being very similar to the way that roads are built. So let's say you have a road and it's just lying there being a road. And then slowly what happens is you get little potholes or you get little weakening, little cracks here and there. And then there's a signal that's sent out to say, it's time that we do something about it. And then a crew comes out and it digs out the old road or the old bone. And then another crew has to come along and then actually form bone. So what happens is this continuing cycle where we have bone which is in a quiescent or dormant phase, which then sends out signals to have these bone remodeling units come and do the resorption to dig out the bone, which then in turn sends another signal to have the bone forming cells come and lay down new bone. And then it's sort of rinse and repeat. And this happens over and over and over again. So when we think about normal bone, it's strong for two reasons. The first is that it's dense enough to support the weight of the individual and the work that we want to do. And it also has the bone quality to allow those things as well. So when we dig down a little bit further, that bone quality actually has three different components to it. Bone turnover, so how quickly is the bone turning over? The bone architecture, what does it actually look like and how does it in a mechanical way help to support the body? And the bone mineral matrix, which is the stuff itself. What is the hydroxyapatite crystal like, the collagen like? What's the quality of the material there? And those three components together form bone quality. And then if you add in the density of the bone, then we have bone strength. So we can then understand that bone can be less strong by affecting any one of these things, and different diseases and different conditions affect different components. So just as an example, if your thyroid is overactive, it leads to bone turnover being too high. If your parathyroid gland is not working well, then the bone mineral matrix gets weak. So different conditions affect the bone in very different ways. And then understanding how bone is made and the components of bone strength, we can then understand what osteoporosis is. So osteoporosis is a disease of the skeleton of compromised bone strength, characterized by low bone density. It means the quantity is low, and low bone qualities, those three other things, which then leads to an increased risk of fracture. So you can see on the right, there's a strong, dense looking bridge that holds up a lot of weight. On the left, the same thing in the bone, but then down at the bottom, you can see a big hole. And that is not going to hold up terribly well. And that's what happens with osteoporotic bone. It becomes like Swiss cheese of weak, not dense enough bone that can not support the weight of our bodies, particularly if there's a trauma. So the reason I'm telling all this partly is that it's going to lead to our conversation around treatment, but also to understand that don't think of bone density as being the only thing to look at when we're looking at osteoporosis. For many, many years, we were really, I think, focused only on bone density. If the bone density is good, the bone is good. If the bone density is poor, the bone is not good. And I really want to emphasize that there's more to it than that. And that's why we have to look a little more deeply. So that can lead us to think about then, well, who might be at risk for osteoporosis and should get checked out? And I'm going to focus on men only. So as we age, all bone gets weaker. So we build bone up until about the age of 30 or 35. And then the bone kind of stays at relatively the same level for most of us. And then it starts to weaken. So by the time we're 65, it's worth it for all men to be checked for osteoporosis. Now, I have to say, as in the new osteoporosis guidelines that are going to come out in the coming year, that number may go up a little bit, but 65 to 70 is a really good range to be thinking about. So no matter what, even if you're in great, perfect health, 65 is a great time to go to your doctor and say, I think it's time for me to be checked out for osteoporosis. But as Larry mentioned, younger men can get this too. And so we look at men who are 50 to 64 who have risk factors for fracture, and men under the age of 50 with one of those specific diseases or conditions that can lead to low bone mass or bone loss. So let's dig into those a little bit further if that's okay with you. So men between the age of 50 and 64, if you've broken a bone after the age of 40, or if you have an x-ray, like a chest x-ray or an x-ray of your back for some other reason, and they find a compression fracture, so the spine has collapsed in one of the vertebrae, or if one of your parents had a hip fracture, so that genetically your bone might be weaker, those are all good reasons to have an assessment for osteoporosis. And the fractures after age 40, particularly the ones that we call fragility fractures, and those are fractures that happen at a walking pace or less, or from a standing height or less, or maybe even the first or second step if you fall and tumble. So, you know, if you're skating really, really quickly playing hockey and you trip and you fall and you break something, that's probably less concerning than the kind of thing that Larry was describing, where you're just minding your own business, maybe a little clumsy, and you just stumble and you fall. Your bone should not break. So be really mindful of those so-called fragility fractures. A high alcohol intake or recurrent smoking. So the research is pretty clear that 1 or 2 drinks is not going to be sufficient to weaken bone, but 3 or more drinks per day is. And so that's the threshold, the limit for the amount of alcohol that we can have. So that's something to keep in mind. Smoking weakens the bone in many, many ways. And we'd need a couple of hours to talk just about smoking alone, but suffice it to say that smoking is not good for the bones. People who are thin, so if you're under 132 pounds or 60 kilos, or you've lost 10% of your weight since you were age 25, that puts you at higher risk for osteoporosis. If you're on some particular medications that weaken the bone, and the most common one would be a drug called prednisone, a so-called glucocorticoid, and another common one for men who have prostate cancer, we deliberately are suppressing their hormones, their androgens, testosterone, and that weakens bone as well, because testosterone is an important component of maintaining bones in men differently than it does in women. And then there are certain conditions, and I've just highlighted a few of them here: rheumatoid arthritis, chronic bronchitis or emphysema, and celiac disease or malabsorption syndromes. Those are diseases that can lead to the presence of osteoporosis as well. And you want to be careful to get yourself checked out if you have those too. And in much younger men, it's those same medications and a number of conditions, including the ones that I've already mentioned. Anything that's a sort of chronic inflammatory condition, the malabsorption things, I mentioned thyroid and parathyroid, so some of the hormonal things. A symptomatic low testosterone level, so not just you get your blood test and you have a low T level, but actually with hair loss and a decrease in libido and those kind of things. And there's a long list of other ones as well, but I think you can see that there are some medical conditions. Really what I would say is if you have a chronic health condition, then it would be worth just asking your doctor, you know, can this weaken my bones? So age 65 or older, or under 65 if you have health issues or those medications that I mentioned. Some other medications too, some of the seizure drugs, for example, like Dilantin or carbamazepine, valproic acid. So really what I would say is if you're on medications for a long period of time, whatever they are, just ask your doctor or your pharmacist to check if they weaken bone. Okay, so another quiz. Which of these men should speak to their doctor about getting a bone density test? 72-year-old man who's never had a bone density, 57-year-old who smokes and drinks 4 beers per day, a 61-year-old with prostate cancer who's on testosterone suppressing medication, a 48-year-old man with chronic rheumatoid arthritis, or all of the above. Beautiful. Thank you for listening. That's awesome. Okay, so then what do? Well, then you get a bone density test. And remember, I was saying that density isn't enough. So what we do as doctors is we then do something called a fracture risk assessment. And there are 2 ways we do that. There's a CAROC, the Canadian Association of Radiology and Osteoporosis Canada, or we do something called the FRAX. And the FRAX takes a number of different risk factors. Your doctor would ask you a bunch of questions and come out with a risk score. You have a 17% chance of a fracture in the next 10 years, or you have a 24% chance of a fracture in the next 10 years, whatever it might be. And then you and your doctor can talk together about whether that risk level is high enough that you should be treated. And what we would typically say is that everyone with a risk over 20% probably should very seriously consider treatment. 15 to 20% is sort of a maybe, and less than 15%, perhaps you don't have to. So maybe now we can go on and talk a little bit about the options in terms of treatment, because I think one of the most important things that I want to really emphasize tonight is that treatment works. So the first point is osteoporosis is common in men. The second point is get yourself tested if you're over 65 or you have a risk. And the third point is that treatment works. So let's go back to how bone is made, because that's going to help to inform how we understand how the treatments work. So the first thing is you want to do the things that are going to prevent the bone from weakening in the first place. So you want to stop doing the things that are weakening bone, like smoking and alcohol. And then you want to provide your bone with good building supplies. And for men in particular, we have evidence that protein is really important in helping to build bone. More so than the evidence we have in women, but there are some studies specifically in men that do support protein as being important. And the details probably don't matter very much, but you want to be getting a sufficient amount. It's about 1.3 grams per kilogram of body weight per day if you and your doctor or a dietitian are helping to work that out for you. But and then we need to provide the building blocks of calcium and vitamin D. And vitamin D in particular helps to bring calcium to the bone. So those are the 3 kind of building block supplies that you want to make sure that you're providing to your bone. And then exercise, and we're going to talk about exercise quite a bit because it's really critical. If you tickle the bone, if you stimulate it, it will grow. So you want to be getting these bone cycles going in the areas where you really want them. And we're going to talk about which exercises work and which exercises don't work quite as well. And then we're going to do things to slow down the resorption. And most of the drugs that we use are anti-resorptive agents. So we're going to slow down those digging machines that help to dig out the bone, because if we can do that, then the cells then the bone won't be as weak. And then finally, we have some sort of specialty drugs that help to speed up the formation of bone. And we use those in very high risk situations. So let's dig into those a little bit more. Exercise, exercise, exercise. So that's probably one of the most important messages I'm hoping you'll hear tonight, is that exercise is critically important to building bone, possibly even more so in men than in women. The bad news, unfortunately, is that walking alone is not enough to stimulate the bone to grow. So I'm a huge fan of walking for heart health, for brain health, for all sorts of other great reasons, mental health. Unfortunately, it's not enough for bone health. And the Osteoporosis Canada website has some phenomenal resources that can help with exercise. So I would really encourage you to go to osteoporosis.ca and have a look. The first thing is proper strength training, and that has to be done roughly 2 days per week. Balance exercises are recommended every day, and that can be as simple as trying to stand on one leg, standing on the other leg, or putting one foot in front of the other and seeing if you can balance first with your eyes open and then with your eyes closed. Trying to do things so that your center of balance sways from one side to the other side, so that you can have some recovery from tipping. Posture awareness, and that's, yeah, I'm always slouching. Making sure that you're straight and symmetrical and not hunching over is really critical, and that's really just a daily awareness kind of a thing. And then finally, trying to get some aerobic physical activity of about 150 minutes per week. And you can break that up into any way that you want. So that could be brisk walking, it can be running, it can be treadmill, it can be bike. It doesn't really matter what form of aerobic activity, but you want to be working your heart enough that maybe you can talk, but you couldn't sing. It's probably a good way to think about it. But I'd really encourage you to go to that osteoporosis.ca website and find the tab of exercise. And I've just put up, for example, Gary. So Gary's a golfer, and he's got a moderate fracture risk. So let's say that's around that 15% risk. And then it takes you through a series of videos in terms of what Gary's workout would look like. So if you're a guy like Gary who loves to golf and has a moderate risk of fracture, this will take you through ways that you can look at your own exercise and see if you can tailor it in a way which is safe and effective. And certainly if you have the option of attending an osteoporosis related exercise class, that would be terrific. They're done, many of them are done virtually now. So the next step after exercise is looking at calcium and vitamin D. And how much is enough is a question that we always get asked. So it's about 1,200 milligrams of calcium per day. And what we say is that diet is preferred to getting it through supplements. But if you desperately need to top it up with a supplement, you can do that, but no more than 500 of the 1,200 coming from supplement unless you just cannot avoid it. So what we typically would say is that your usual diet, whatever that is, has about 300 milligrams of calcium. And then every serving of dairy has about another 300 milligrams of calcium. And there's a whole bunch of other foods that have calcium as well, almonds and broccoli and all sorts of others. So again, on the osteoporosis.ca website, there's a great calcium calculator, and you can add up what you're getting in your diet and see what you can improve. And then if you're not able to get up to that 1,200, then to add a little bit more if you have to through a supplement. And the reason we don't like the supplements is really more that they're more likely to cause bloating and constipation. They can bind to other medications and so on. So that's why getting it through the diet is really preferable. In vitamin D, there's a range of 800 to 2,000 international units daily. I usually just say to take 1,000 for convenience. And we don't have to check the blood level of vitamin D. We just need to start the supplement. If you have osteoporosis and you're on the medications that we're about to talk about, then what your doctor may do is, after you've been on vitamin D for 2 or 3 months, they might then check a blood level, and we want that level to be above 75. So if you're looking for a target in blood, it would be about above 75. So that's calcium and vitamin D. And then for people who actually have osteoporosis, then we use medications. And I think it's really, really important to emphasize the medications blow everything else out of the water. So if you use calcium and vitamin D and exercise, you might prevent, 3% of fractures or 5% of fractures. But when you're on the right medications, it can be 30 to 40%, and with some medications, 50%. So don't think that if you have the disease, that calcium and vitamin D or calcium and vitamin D and exercise alone are enough, or protein. they're necessary but not sufficient is the way that I describe it to patients. So remember those resorptive drugs. The drugs that stop resorption are the ones that, if there are some on the call who have osteoporosis, you're probably on one of these. Risedronate, alendronate, zoledronic acid. I put the trade names there as well. And many of them now are in formulations that are quite easy to use once a month. Remember that these are sort of fickle kind of drugs. They're sticky. So you have to take them with a full glass of water. You have to remain sitting or standing for half hour to an hour afterwards. And you don't want to eat any food within that period of time, because these drugs don't absorb well, and we want every little bit that we can to be absorbed into the body. And they can be far more effective if you take them on an empty stomach. Then there's another drug that some of you may be on called denosumab or Prolia. And it works slightly differently, but it's still an anti-resorptive. And the advantage of denosumab is that it's an injection which is given once every 6 months. And so you don't have to remember to take it regularly. And it's also highly, highly effective. Your doctor may want to check your calcium level before you start on this medication, but it can work very well. For people who have very severe osteoporosis, let's say they've broken many, many bones before, or their bone density is extremely low and their risk of another fracture is 30% or 40%, then we have a whole other group of drugs that are called anabolics, and those are the bone forming or bone building drugs. And the one which is used most commonly is called teriparatide or Forteo. And some of you may be on that medication. It's not used as often, but is highly effective for people who have really severe osteoporosis. And then just to talk about one that's sort of in the pipeline and just released is a drug that I'm not going to go into the details, called romosozumab. And it can be highly effective as well. So there probably will be more about that to come, but I wasn't going to focus on it tonight. And I'm happy afterwards to answer questions about these drugs if you'd like. They act differently. So the bisphosphonates actually go right into the bone, and they lie directly in the bone. They're like squatters in the bone. And so they have a long, long action. And even if you stop the medication, they're still in the bone for a few years afterwards. Whereas the denosumab acts in the bloodstream. And so as soon as you stop taking it, there's no more action. The reason that's important is that there are some situations now where we're suggesting to patients that after a certain number of years of treatment, that's enough and you can stop. And you'll still get benefit from the medication for another couple of years, 2 to 3 years, and then you may start on medication again. So it might be an on-off kind of a thing. But there are some people, particularly who've had multiple fractures or a hip fracture, where we are recommending never to come off the medication. So I would encourage you to speak with your physician if you've been on one of these drugs for a long period of time to see if you're a candidate or not a candidate for a drug holiday. All right, so another poll. Can I still have a beer? Yes, but you can't have too much. No, yes, and you can't have too much. The more the merrier. No, you can't have any. Or yes, you can have some in moderation, and I guess I can live with that. What do you think? Absolutely. Yes. So as I was sipping my beer, I hope that was a bit of a clue as well. And I was happy to see that as well. So that's really all that I wanted to say tonight. I'm happy. I tried to leave a little bit of time at the end for questions, but what I've tried to do is give you a bit of an understanding of what I think is important. First, that osteoporosis is a common and really serious disease in men. I want you to get screened if you're over age 65 or you're younger with any risk factors. Treatment works. It really works. So don't hesitate to take it if you need it. Stop smoking. Exercise, but not just walking, the strength and the balance and the posture and the aerobic. There's 4 components of a proper exercise program if you have osteoporosis. Make sure you're getting adequate calcium, adequate vitamin D, and adequate protein. consider the medications because they're very effective. And maybe the most important thing is getting any chronic, a diagnosis of any chronic illness is hard. And people, particularly with osteoporosis, I've seen in my own patients, they get very frightened and they don't want to go out and do things because they're worried that they're going to break a bone. So what I would say is still live life, have beef, have beer in moderation, and have good cheer. So with that, I'll turn it back over to Larry.
Thank you very much. I said that was excellent. I think Liz has a couple of questions that she'd like to ask as well in a poll.
Yes, thank you, Larry. And thank you, Dr. Feldman, for providing this valuable information. And as well, Larry, for sharing your story with us tonight. We gratefully appreciate both of your time and expertise. Yeah, so I do have 2 last poll questions before we close for the evening. So if Arvind can put up the second to last poll. So when it comes to activities to help prevent or treat osteoporosis, such as support group or exercise program, would you prefer men-only sessions? I'll give you a second to answer there. Okay, that's interesting. So no, okay. So you would be okay to be with some of the ladies then. So that's great. Okay, so our last
Maybe
poll.
ask you, would the women rather not be with us? That's the question.
All right, and so again, we have one last poll question. So this question is, how comfortable are you using technology for activities or consultations with your healthcare provider? So very comfortable, somewhat comfortable, not comfortable, or don't know. So just a few seconds for that. Oh, that's great to see. Very comfortable. So it's really great, Dr. Feldman. Yes?
It's wonderful.
Yes.
Yeah, great to see.
Excellent. All right. So that concludes our poll questions. But I do see our time here, and we do have a few minutes to answer. We have time for 2 questions. So to you, Dr. Feldman, I have a couple of questions here.
Sure.
So the first is, do men need to do more walking to avoid low bone density?
Right. So unfortunately, walking alone isn't enough to prevent low bone density. That's why we need to have higher pressure on the bones than just walking in order to stimulate the bones enough that they'll start to grow bone in the right places where we need it. So walking is wonderful for so many other things, but it's not sufficient to build good bone.
Okay, thank you. And the other question I have here is, do men diagnosed with osteoporosis take the same medication as women?
Yes, men can take the same medication as women. There's more evidence for some than for others, and different provinces had different payment systems where they might pay for one of the bisphosphonates, but not necessarily all of them. But yes, the answer is that they work the same for sure.
Okay, great. Well, that is all the time we have there for questions. So thank you very much, Dr. Feldman.
Liz, I do see a few questions in the chat. If I can try and answer those fairly quickly, if that's okay.
Oh, I'm sorry. Yes.
So the question around regarding the dangers of stopping Prolia is really a very important one, because there are some studies that show that if you abruptly stop Prolia without switching over to a bisphosphonate or some other medication, there may be a rebound risk of fracture. So I would really encourage you that if you've been on it, whether it's for a longer time or a shorter time, before stopping it, to really check with your doctor about whether that's okay or not. And then I see a really important question as well about atypical femoral fractures. So what happens with these medications, they have benefits and they also have some risks. And the longer you're on the medication, the higher the risk. And one of the risks of the bisphosphonates and also denosumab is a fracture of the femur lower down than up in the hip. And that can happen in men and in women. The really critical thing to remember is that it starts with thigh pain. So if you're on one of these medications and you develop pain in your thigh, go to your doctor right away and tell them. And they may want to do a bone scan or at least an x-ray to have a good look and make sure you're not starting to have a little crack. And that's why we have some people where we try and take them off earlier if we can, because the longer you're on the medication, the higher the risk of atypical femoral fracture. Does stair climbing help? Yes. So stair climbing is definitely something that would help because you're putting additional weight onto the hip. So stair climbing would be a great way to do things. And then there are a number of questions around, I see Tom has one. Are there methods to measure bone density other than with BMD? And yes, there are ultrasound methods that may not be quite as accurate, but that may be appropriate. So that may be another option that's available if you don't have access to BMD. Remembering that bone mineral densities don't have to be done every year. They can be done every 2, every 3, sometimes even every 5 years, depending on the situation you're in. So it may be that BMDs aren't available, or it may be that the BMD isn't necessary yet. So I'm not sure quite which of those it is. There's a question around side effects of nausea and vertigo from the bone medications. That's a tough one, and how to get beyond them. So there is one formulation of one of the bisphosphonates, the DR form, and that can be taken with food, the Actonel DR. So that may be one that would be a little bit better in terms of nausea. And then many people find that the nausea with denosumab with Prolia is less. So that might be another possibility. I think that's rapid fire answers to great questions.
Okay, wonderful. Well, thanks again, Dr. Feldman, for answering the questions and of course, sharing your expertise with us tonight. So I just have a few slides to close off the evening. Okay, so before you go, I just want to mention some information where you can visit through our website. We have a couple of links. First, the calcium calculator, an easy way to calculate your daily intake. And also share or take the Know Your Risk quiz. We also have our OC podcast, Unbreakable, which features evidence-based information and personal stories from those affected by osteoporosis. And also we have the OC Replay, which features recent webinars on bone health and osteoporosis. Now this webinar today has been recorded and will be available on the OC Replay website in the next 48 hours. And also we want to thank again our partner, thinkbeef.ca, for partnering with us on this webinar tonight. And to conclude this evening, I would like to again thank you, Dr. Feldman and Larry Funnell, for taking the time to share with us tonight. As well, thank you to everyone who joined us. Please stay connected. Visit our website at osteoporosis.ca and follow us on Facebook, Instagram, and Twitter. And cheers and have a good evening.